Good morning, and welcome to the 2026 Goldman Berlin Lectureship in Palliative Medicine, hosted by the Providence Center for Healthcare Ethics in partnership with the St. Vincent Medical Foundation. I'm Kevin Dirksen, Director of the Ethics Center and holder of the Andy and Bev Hansel Endowed Chair in Applied Healthcare Ethics. This morning, we're broadcasting live from Providence St. Vincent Medical Center. You can earn continuing education credit by being here in the room with us, by watching the virtual event, or by watching a recording. Our team will be monitoring the Q&A field throughout the session, which will hold to the end as time permits. Before introducing today's speaker, we'd like to acknowledge dueling milestones. This year marks both the 25th anniversary of the Providence Center for Healthcare Ethics and the 20th anniversary of the Goldman Berlin Lectureship in Palliative Medicine. Nearly since the center's founding, this lectureship and our other programming have played a central role in advancing healthcare ethics at St. Vincent, across the Providence footprint, as well as contributing to the field nationally and internationally. This means that our team at the center and those who came before us and have supported us share a deep commitment to providing patients, their loved ones, and those who care for them with thoughtful ethical analysis and guidance in the midst of the most difficult of ethical situations. Crucially, the center's approach and method is not to train clinicians when to call ethics to make the hard decisions, but to learn how to navigate dilemmas through ethics coaching, consultation, education like this morning, and vocational development. But this morning, our attention here and on the next installment of a 2-decade history of the Goldman Berlin Lectureship in Palliative Medicine. Named for two Providence St. Vincent clinical giants, Drs. Robert Goldman and John Berland, they distinguished themselves in providing excellent whole-person care that we now know today as palliative care. This year is particularly special not only because we're celebrating the 20th anniversary of this lectureship, but because of who our speaker is. Selected by our St. Vincent Ethics team and our planning committee chair, Dr. Mark Carr, our ethicist from the North Division in Alaska here with Providence, and in dialogue with our palliative care leadership and Dr. Juan Irigue, we are excited to introduce you to Dr. Gretchen Berland this morning, daughter of one of the namesakes of our lectureship, Dr. John Berland. It's been wonderful, Dr. Berland, hello, Dr. Berland. It's been wonderful getting to know Gretchen over the past year in planning for this lectureship, and it's great to see several members of the Berland family in our audience this morning, including John. Welcome, and thank you for being here. What a wonderful way to celebrate a 20th anniversary of our lectureship by continuing to explore important themes regarding Dr. Gretchen Berland's research and scholarship and service at Yale School of Medicine. So, Dr. Gretchen Berland is a professor of medicine at the Yale School of Medicine and has been a practicing general internist for over 2 decades. She works in both the inpatient and outpatient arenas and serves as director of one of the inpatient medicine rotations for the Yale School of Medicine Internal Medicine Residency Program. She attended medical school here in town at OHSU, completed residency at Washington University School of Medicine in St. Louis, and a research fellowship with the Robert Wood Johnson Clinical Scholars Program at UCLA. Prior to pursuing a degree in medicine, Gretchen was a contributor to Nova and PBS NewsHour, utilizing film to explore the lived experience of patients and teaching several courses on the relationship between media and medicine at Yale University. Dr. Berland is a MacArthur Fellowship recipient, has received several Emmy Awards for her work in journalism and filmmaking, and has been recognized at Yale School of Medicine for her teaching attributes and commitment to practicing high quality and equitable care for vulnerable patients in the New Haven community. With that long introduction, would you please help me welcome Dr. Gretchen Berland?
All right, let me get settled here. Can everyone hear me? Well, thank you. Wow. Thank you for that kind and generous, thoughtful introduction, Kevin. And thank you to the Providence Center for Health Ethics for inviting me to this talk. I'll just say it's really great to be home. It's really nostalgic to come back. Thank you to all of you coming here in person today and online for making time to spend time thinking about things that I do for a living. It's always a little strange to hear about who I am because I think what you're going to hear about today is mostly about kind of what I do. I'm going to say I row in the boat. I'm a boat rower. I live in the trenches. And when I was talking earlier this year with Kevin and Mark around sort of talks for this, it's a real honor and privilege to be here. But I want to say that as I was the title of my talk today, Hospital, Society, and Health, an Urban Case Study, it's a PowerPoint title. Really, the title is about people and space and places and creating spaces of belonging for patients, for providers, and flying from New Haven to Oregon. It's also, you have time to think on a plane. This talk is about kind of the constellation of experiences and moments that have shaped who I am as a physician. And some of the media mentors and other mentors, which you'll hear about a little bit today and tomorrow in my talk. But time zero starts with my dad. That's where growing up, I get to, you all get to see him come here to work, but I get to see him when the phone rings in the morning. So I just can't tell you how special and meaningful it is to have my dad and my mom and my sister here for this hour. So thank you for letting us do that today. So here's the PowerPoint slide. I have no disclosures. Also, I'm an introvert, so right now I have no saliva. But once I take a little bit of water, it will come back. And can everyone hear me? All right. So let's start with slide 1. Who am I? I am what Kevin told me about, but I'm more comfortable with this. I am a PGY 30. So those of you in medicine know, this is postgraduate year 30. I was also thinking on the plane, what is this postgraduate days? And I thought, I'm just not going to share that with you, but it is high. And the reason I bring this slide is this very much is who I am. I have my life, my formative professional life has spent thousands of hours, hundreds of thousands of hours in academic tertiary care hospitals, which is what I'm going to talk about today because I find them to be interesting places. And then, which is where I work on the left, which we're going to spend a fair bit of time diving into. And then here on the right, which is one of our federally qualified health centers where I also work. I wear 2 hats. I work as an inpatient attending, which I'll tell you more about. I also work as an outpatient attending, and I have really since residency have worked mostly, actually exclusively in underserved environments. This is one of our 2 large federally qualified health systems for which there are other multiple sites. So I sit in both places and straddle both worlds. So I'm a PGY 30, which is a gratifying but sort of terrifying milestone at the same time. But that's kind of who I am, and that's where I center kind of my experience in some of the talk today. So back to the kind of PowerPoint version of where are we going this morning. First, I know there's one person here who's been to New Haven, but for those of you who have not, I'm going to give you a brief tour, I think, of just some of how I think about place as a physician now. For those of you who have been to New Haven, just bear with me. It might be a tiny tour of welcome back. The meat of the talk are sort of the next 2 parts. One is to describe the evolving landscape of an adult inpatient medicine service, which is a big part of my professional career. The events there, and I know from the case that I'll be talking about tomorrow, it's clear that New Haven, we are not unique in some of the issues I suspect I'll be talking about today. And then amidst some of those changes and stressors and change, how can we, since everyone here in the room, and I'm assuming online, we go into medicine or healthcare because it's a service. There's a piece about this that is about sacrifice and mission and commitment. And there are times in our days and our lives when it's really hard to do that. So how can we, and there's no magic answers in this talk. This is just about sort of the journey of kind of how to find really places where people can belong, patients and providers. So how can we preserve the mission of treating patients and families with compassion and dignity? So first, Connecticut, which I will say is a small state. I realized this morning you could actually drive around all the four corners in one day. It's probably the size of a county, 70 by 110. Population's around 3.6 million. And if you take a snapshot of the state, it's a very pretty state. A lot of deciduous trees and green, way too many ticks, too much humidity. But just to give you some overall life expectancy from 2024, pretty good by national average, 80.8 years. I would say the middle bullet slide, even though that's what I'm here, more than 57% report more than one chronic health condition. And adults without health insurance is 7%. That's actually a pretty good number, sort of given where we live within the US health system. And that's partly because those of you who've been in Connecticut, like other states and like our United States, we have pockets of great resources and pockets of great need. Driving south to New Haven, a little bit of a different story, but it's been home for a long time. So I want to show off some pictures and who this place is. One is that we have 134,000 citizens. This is a picture of the New Haven Green. Just to give a sense, we have our court system, our New Haven Public Library, we have churches. Many of our vulnerable citizens spend time on the New Haven Green, and if you look up in the higher end here, there's Yale University. If I were going to give you a tour and point over to the far left, which we will in a few slides, New Haven Hospital is just about 6 blocks away. But when you come to New Haven, life expectancy drops. And this source here is from Data Haven, which is a wonderful resource that's been created in the state of Connecticut since 1992, which really is about creating neighborhood level data sets to provide information to help communities understand where their needs are and how to improve kind of overall community well-being. Life expectancy in New Haven, and I will say would probably be the same in Hartford and Bridgeport, is much different than the normal state, often a range between 71 to 78 years. 10% of adults have no health insurance. And then down here, I just want you to look at some of the pictures of the blue. Thinking also the larger question of who gets to be healthy in the United States? Who gets to be sick in the United States? And in New Haven, we have significant need. We have, if you look at the proportion of Latinos over the age of 65 who have diabetes, that's over 50%. Look at the patients who are Black and Latino who have hypertension. We're looking at 3/4 of individuals who have those conditions, and this has been happening for decades. So to potentially chip away at making this better also takes a lot of time. Also thinking about place and space and community, we had a really hot winter, so I have to start with this beautiful slide on over there. And that's also thinking about what makes communities healthy, what makes us belong, where can people go in our city of 134,000 citizens. And I will say that New Haven really tries to make, I think there's a lot of commitment to making the city better for people and equal for people. New Haven is a small city, 21.2 square miles, and of that 17%, almost 18% are park spaces. We've got over 16 parks. You can walk. This is the Worcester Square Park, which is a really beautiful park down kind of in the Little Italy area of New Haven. This sign I drive through on my way home, we have significant dedication to provide high quality food access, food entrepreneurship through an organization called City Seed. They not only have farmers markets, but they have farmers markets out of federally qualified health centers. They have programs to help first generations families create businesses where they can supply food to communities. So it's a real mission thinking about what health is defined as. And then here, kind of on my right, one of my favorite places I drive by is New Haven Reads, which has been in existence since 2001, which provides one-to-one volunteer tutoring for individuals who really have who need better reading skills. And that crosses adults, children and adults. They've served over 10,000, I think, since 2001. So that's just give you a sense of kind of health and place in society. We also have programs thinking about, even though 10% of New Haven, that's 13,000 citizens who have no health insurance, and an N of 1, as you know, to build infrastructure for people who have no health insurance takes a lot of time and a lot of effort. We have programs like Project Access, which is created here at New Haven by one of my colleagues in my section, which is really designed to provide medical services for individuals who will never have access to health care. And it's not just the access to the appointment, it's taxi services, it's patient navigators, so that people can get connected to services for the healthcare that they need. Thinking about that blue statistic of hypertension, we have a project called Project Pressure Check New Haven, Find Your Path to Better Health. This is a four-city project that's partnership with the School of Medicine, the School of Public Health, ran by a cardiologist named Erica Spatch, which is really trying to, and multiple communities across New Haven, think about the churches on the New Haven Green, to really reach citizens who have either high blood pressure that they're not aware of, or potentially create more partnerships so they can have better control of that blood pressure. So these are just giving you a sense of, when you drive through your community, what is it that makes a place healthy for me? What access do I have? And then the mothership, where I work. As you know, hospitals love concrete, but this is an aerial view of Yale New Haven Hospital, which is a very large hospital system. It's very much a part of New Haven. Hospitals, for those of you who are interested in hospitals, there's a lot of it. I would define it as a complex adaptive system that over time has evolved because of technology, culture, need. And so it's a complicated but interesting place. Yale New Haven is a big place. It has 30,000 employees. I work here mostly. This is our kind of our medicine hospital, which is sort of far to the right. And also, it serves a significant need for our community, often for acuity, often in times of great crisis, often in times of when we've had social, cultural failures or gaps in our system, that hospitals sort of pick up that and absorb all that. And that is part of the reason we have some of the strain that we do in our healthcare system. So now that you have a little sense of where I've been and where I live, I forgot, you also know too that New Haven is the pizza capital of the world. I'll just keep that out for today. There are other people who may have strong opinions about which is a better place, but it does have that reputation. I thought, do I take a picture? I thought, no, we'll stick in health. So the next space I want to talk about is the kind of evolving, I guess, hospital, society, and health. We're going to move back to hospitals, hospital, society, and health. And this is where the big chunk is to describe the evolving landscape of an adult inpatient medicine service. I'm right up here on the 9th floor. I was not there that day, but that's where I spend most of my time. So to give you a sense of it, that is very where I have been for the last 8 years in this role. And as Kevin alluded to, Yale New Haven Hospital, the internal medicine program, and I assume it's like many programs, our inpatient rotations are localized to different floors, which we call firms. It is the primary inpatient general internal medicine rotation for Yale internal medicine residents, medicine pediatric residents, medical students at Yale, physician assistant students at Yale, as well as we have students who come in from abroad and rotate with us between 2 and 4 weeks at a time. This is a wonderful picture of 2 of my attendings and our residents and students. The attendings sit in the Yale section of general internal medicine. It's a really, I would say, devoted, committed group of providers who bring a wide range of interests and experiences to the inpatient rotation. Just to give you an example, J.D. Talwalker, the gentleman next to the painting, he's the associate dean at the med school, does a lot of work on artificial intelligence. Next to him is Pinar Reshram, who works with me in the outpatient setting and runs the Wednesday evening clinic. So these are physicians who come and attend for 2 weeks at a time, but very much have a deep clinical, I think, expertise that they bring to the bedside and the team. And the residents, the feedback is they really like that. We have other physicians who do work on incarceration or addiction. So that's where I work. I just want to talk for a quick second. When I first became firm chief, it was actually named the Generalist Firm. But in 2023, a beloved colleague and friend, Dr. Laura Whitman, died. She was the former Yale chief, internal medicine chief resident. She was the associate program director of the internal medicine program at Yale. But she was really a master clinician and role model who was devoted to serving vulnerable populations, promoting health equity. And we know promoting health equity at the top is actually practicing it and implementing it is much harder to do. And working for vulnerable populations was her North Star. So renaming the generalist firm the Whitman firm after her was really, for us, something very special. Also partly because it's the only firm at the hospital that's named after a woman. So Laura, we have no picture of her. She actually probably would kill me if she knew that she was in this grand rounds. But I get to say her name at least 2 to 3 dozen times a day. It says patient going to Whitman, going to Whitman. So that's a really nice way to kind of honor her legacy. So that's who we are. And I think her mission of really doing the work on the ground is what we try to do at the firm. So just some overall priorities, philosophical priorities of the Whitman firm. And I'm going to say this is probably most inpatient medicine rotations across the country. The top 4 are really our priorities in terms of what we as a floor unit prioritize: communication. I will spend the rest of my career refining communication. Communication is a procedure. And as you all know, that communication problems are usually what end up with medical errors and serious safety events. So we really prioritize on communicating with colleagues, communication with patients, patient demographics. One of the first things I look at, is that patient's face sheet. I want to know where that patient came from, what their health insurance is or not, because it doesn't matter my financial issue, but it's going to influence what infrastructure I need to build for that person in order for them to go home if we have that. That's just the world that we live in. Do they have a phone number? Do they have an emergency contact? So part of that, right, is around getting a better sense of who this patient was before they came to our floor. We also try to think about concepts of was this patient well? When did they have an A1C that was controlled? When were they not in the hospital 5 or 6 times or 7 or 8 or 9 times a year? We really prioritize minimizing depersonalization, and that has really become, I'll talk a little bit about that more tomorrow, a major priority in terms of my professional career. Hospitals, right, for me, are normal places. I'm comfortable working in a healthcare system. It is a normal place where I go to work. I have control. But for most of us, for if I were to become a patient or have a family member who became a patient, it immediately becomes a very stressful environment, very depersonalizing, right? We take away your clothes in the emergency room. Usually we take away your phone. It's not a place, it's a place where people have a lot of loss of control. So we really try to minimize that or recognize that as much as possible. Another area that we consider here is stigma reduction. We have many individuals who are admitted with complications related to use disorders, and stigma reduction is always a place where you can potentially have a conversation with the person who's hospitalized to make them feel like it's not their fault. For learners, we believe in creating a horizontal learning environment, meaning that everyone is a learner. There is no question is stupid. If you potentially did not identify that critical lab or vital sign, that doesn't mean you're a failure. It just means that this is part of the learning experience. So we try to balance support and autonomy. That's a real philosophical approach that we bring to the floor. Wait a second, sorry. So the good news is we're not alone. And I think that we have a lot of resources to help us do this, like a large major tertiary care center. We have addiction medicine consults team. We have ethics. We have interventional radiology. We have palliative care. We have an embedded care coordination teams. We have complex care management. We have pharmacy, thank goodness. Lots of all the services that you see in most healthcare systems: nutrition, occupational therapy, speech therapy, social work. Patient relations, we need this now. We have hospital security, we need this now. A behavioral intervention team. So we have the resources that I think partly are created in response to the needs of the system, but we utilize them a lot. And we have pretty good throughput metrics, I'll say. For those of you who sort of are living in the world of patient safety and quality, you need to know that the observed to expected mortality ratio, you want to be less than 1. You don't want to be more than 1. More than 1's not good. Our average length of stay for a teaching service is not bad. It's less than 7 days. Our discharge home, we try to get patients to go home and stay home, is 89.2%. And our 30-day readmission, Yale still has work to do in this area, is about 12.2%, which is pretty good for a teaching floor. So I think that we really try to build infrastructures for patients to go home and stay home if they possibly can. But there are trends that I have seen mostly since in my job. Hospitals are full. Hospitals are very full. Patients are sicker. There's more inadequate insurance coverage. I have had to participate in more peer-to-peers with insurance companies, I would say, over the years. It's just increasing in frequency. Longer hospital stays, patients are sicker, so they're staying in the hospital longer, but also they basically need infrastructure that doesn't exist in the community, and so we need to figure out how to create that. And that creates a lot of stress in the system. We have complex discharges. You know, we used to think about building within the hospital system that right, the admission part is kind of the fun part. It's like the fever of unknown origin or the severe vitamin A deficiency. That's kind of the fun part, but you've got to start to build infrastructure from time zero. And all of this, we have workplace violence, which I will say is probably one of the most surprising parts of my job. I didn't expect I would be encountering that much of it in my job, but it is here. I don't think it's going away. It is pervasive and significant. And that some of this all contributes to provider fatigue. So I want to spend a little bit more time on some of the trends. We know nationally hospitals are full and patients are sicker. Just to give you some overall national trends, partly think, well, Yale New Haven's not alone. This is a paper a cross-sectional study that came out in Health Affairs in 2025, kind of looking at emergency room boarding. I have to say, I've become if anybody's going into emergency room, you're going to wait. So waits are much longer. Here shows that basically in January of 2022, 40.6% of hospitalizations, this is looking at 46 million admissions between 2017 and 2024, spent more than 4 hours waiting in the emergency room, which is that once you get above 4 hours in an emergency room, get up to 24 hours in an emergency room, outcomes are much worse. The emergency room is not a safe place to be. So hospitals are full. And this is just a marker of capacity strain, right? This is just a marker of when I think about a hospital system, it's like how much smoke is coming out of the top of the roof, right? Is it flames or is it just smoke on any given day? And patients are sicker. This is from Vizient Data, which is sort of a large kind of organization that provides a lot of performance data to academic hospital centers. Acuity is on the rise. And yet mortality has declined. So we're doing a better job of taking care of our patients at the hospital. Hospital-acquired infections are lower, but patients are sicker. And what does that mean? Patients they're older, but it's not just older. I'm going to say, I think a lot of see the data in age, but it's younger. They have more than 5 medical problems. They have more than 5 active medical problems. And that is very much our experience in New Haven. Just to give you a trend, so as you know, hospitals kind of work well when they're sitting at 85 to 90% capacity. You get above that, and the car starts to break and starts to get stressed. We run between 97 and 100% capacity all the time. I get 3 emails every day around 6 o'clock in the morning. First is the patient safety report. Second is hospital capacity. This is just a slide shot, I will say, between the time that I was notified about the lectureship and now. And I have to kind of brace myself when I open the email. So here's a capacity. Volumes have tripled in the ED over the past, I get this every day, over the past 24 hours. Please seek out all safe and timely discharges, share your teams. Just look at the capacity right there, 77% ED boarders. That's York Street, my main campus, 60, waiting for medicine beds. 2 have been waiting for more than 24 hours. We've got a MICU patient that's unassigned. 6 patients sat in the PACU overnight. That's our post-acute care unit from a procedure. And we discharged 201. So this is every day. This tells me what's the level of the temperature and stress in the healthcare system, which then takes me to my sign, to my 9th floor. Patient resting in the hall. Be mindful of your noise level. Thank you. That means some poor soul, A, has gotten out of the hospital, out of the emergency room, but B, this is when we sort of hit super capacity crisis, on fire, and they're going to basically sit in a bed outside of our pharmacist workroom, and they're going to stay there really until they go home. And And it used to be in the winters, it used to be certain types of day, but no, this is kind of more our norm. And as soon as that bed is someone discharged, that bed is turned over. So we are just busy, 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 busy. Patients are sicker. This is from our COVID pandemic. They've been sicker since the pandemic. This is just to give you a kind of a snapshot. I'll say, as Kevin did graciously, I'm a researcher. I'm very much a practicing clinician, but just giving a sense of patient factors of admission, looking at some of our Whitman firm over the last, just looking at this has been over time. Many of our patients have been in the hospital, hospitalizations in the prior year, 30%. They have more than 5 active medical issues. They are sick. Many of them have had more than 1 ICU stay. I mean, many of our patients, an ICU stay is normal for them. At least 10, if not more, have unstable housing, unsafe living conditions, and about 20% are conserved or need conservatorship. So that's like that piece too. In terms of diagnosis, sepsis is still very much there. That's quite common. That has not changed. But what is evolving is the complications of uncontrolled diabetes. And it's uncontrolled diabetes in young individuals, not 60 or 70. I can say 60 because I'm 60, but it's 30. It's 35. And you look, and there's been an A1C of 11, 12, 13, 14 for years. It's really hard to take that back. We have exacerbations of a prior diagnosis, volume overload from heart failure, right? You know this, encephalopathy from decompensated cirrhosis. I will say a trend we're seeing is new malignancies diagnosed in younger patients. Someone coming in with new back pain, and that is metastatic disease. This is a new trend that we're seeing. And complications from substance use disorders, alcohol, fentanyl. We have xylazine there, which is a vet medication that creates a lot of serious ulcers. We have long hospital stays. About 1 in 7 of our patients has a prolonged hospital stay, and I'll say even that technically definition is more than 21 days. But 21 days seems like nothing to me now. I mean, I have patients on my floor that are 175 days, so I'm like, oh my God, I'm normalizing prolonged. Just within the last 2 months, on our floor, we had 2 that have been there more than 30 days, 2 that have been there more than 60 days, and 1 that has been there more than 365 days. Which I'll talk a little bit about tomorrow. They're not old. Many of them are young. Often they have no families. The infrastructure that was created for them doesn't exist, and we've got to build that back. What are some of our discharge barriers? Meaning they have active medical issues. They're still really sick. Facilities can decline patients. So that's a real issue. I can imagine this is the same in Portland. We have patients because of behavioral issues or what have you. Facilities say no. And Connecticut being a small state, they will often reach across. You look at, they've tried 170 facilities and it's still a no. No payer source or inadequate payer source. They need guardianship, right? We're connected. Healthcare systems are not their own silos that we would like to be. They are connected to probate courts. Probate courts don't operate on our time. They don't understand about a crowded emergency room, which makes me a little crazy. We have people who need very complex DME. I've got someone who got severe obstructive sleep apnea who really cannot survive, cannot live without BiPAP, and they have no insurance and will never have no insurance. So how are you going to build that infrastructure for them? We have patients and patient surrogates who decline discharge. They want what we don't have available. That gets to be tricky. And then there's just no community support. So all this influences in the prolonged stay, and that can be stressful. I know there's been talk about what a complex discharge is. I view complex discharge as just the need for more infrastructure. You need to build a lot of infrastructure for some of our patients. Where are they going to go? This is our amazing care coordination team created this checklist for us because we feel a little naive when it comes to this, and thank God we have them. Do they need new lines? Do they need to go out of state? Do they have new injectables? Do they need wound care? Do they need wound vac, right? We put tubes in places for people that they go home with, lines and drains. They need new oxygen. They now have a new cancer diagnosis? Do they need chemo and radiation? Like often, do they need TPN now? Huge infrastructure related to big change in their lives. This all takes time. And then sort of talking about our last trend, which is workplace violence. Definition of so this sign here, I would say I know when I came with Kelsey to visit the Providence Portland Medical Center last week, you have the same signage. The environmental awareness around workplace violence really started to tick up in after the pandemic. These signs are everywhere you go. So just a reminder of what a definition of workplace violence is, right? It is it's either is an act or perceived act of either physical violence, harassment, intimidation, or disruptive behavior in the work setting. Sadly, in healthcare, I think I'm glad that there's more awareness, but it is here. This is a statistic from the National Bureau of Labor. 70% of work assaults in the U.S. occur in healthcare settings. Now, most of those studies happen in the emergency room and psychiatry units, but they make their way up to the medicine floor. This is an old survey, and I really feel that the numbers are higher. 40% of internal medicine residents experience workplace violence. Psychiatry residents experience way more workplace violence than we do. The third bullet here, I actually think this underestimates the type of the prevalence of aggressive events and exposure rate to workplace violence and microaggressive behavior that healthcare providers have experienced since the pandemic. It occurs at least almost a quarter of the work shifts. And for us in medicine, though I have dealt with my fair share of physical workplace violence, verbal, the chronic microaggressive tendencies, which is right. That's a microaggression is like a brief form of kind of daily, chronic, hostile, derogatory, negative communication. And micro is not meant because it's small. Micro is intended because it's chronic. It's a slow drip. And I think the thing that's most difficult about workplace violence, it's just so sudden. It just comes out of the blue. It just, even though you think you know about it, it's still a really hard piece of what's in our workplace now. And verbal assault is the most common for us. So just like it is here. I hope it's not here as much as, but I bet it is. So my other email that I get in the morning, I get the Medicine Morning and Safety Report, the MMSR roll call worksheet. This is from one day. So this is partly most of the reporting, actually, if you look at the workplace violence literature, is underreported because what they're really reporting is physical assault. And I think that's important to know because that's just a marker of system stress. Thinking about hospitals as porous workplace systems, people bring in stress, uncontrolled stress into their life. You take away that control, you put them in an unfamiliar environment, and maybe the coping strategies that they have, and we live in a society that now said the way to communicate is through violence. Well, we have it. This is from our York Street and St. Raphael's campus. It's combined one day, patient biting staff member, patient tried to assault provider, remains verbally abusive, patient threw tray at environmental associate, patient hitting, kicking staff. This is hard, it's lingering. What are some of the risk factors? Wait times. You make people wait. You make people wait in the emergency room. You make people wait for food. You make people wait for pain medications. And it's going to get tough. You don't manage their symptoms well. Nurses often are kind of on the front line of this, but we are not immune. And where it gets complicated around unmet expectations, and that falls into kind of the microaggressive territory. So it's very much part of our world. And I would say in this, in the last, really since I feel like my life is pre-pandemic and post-pandemic. There's like that real divider, even though it's PGY30. Yale is working really hard to make it better. Partly is that you're not alone. You should not, it's not that, this is not something that you should have to, so let me just back up a second. There's a difference between being a grumpy patient and being an abusive patient. I think we all know that difference. I think it's okay to be grumpy if you're not feeling good, but it's not okay to, I can fill in examples that I think you all know of. There's a difference between that. So I want to make sure that we're not saying that we expect you to be this, grateful patient all the time. I understand that it can be a very difficult experience. I think workplace violence is a little bit like smoke. We kind of know it and we feel it when we experience it. And the institution, it's not just signage. We really try to provide support during and post-incident. We have debriefing, formal and informal debriefing. The med school, the ACGME program has a lot of resources for individuals because some people, their experience of that event may be different than others. We have training. I'll talk a little bit about their multiple sort of frameworks for this. There's no perfect one. You probably won't have one that's going to be a clinical trial that's going to tell you the be all and the end all. I think it's the philosophical approach that you are not alone. And that we are here to support you. So the one we use a little bit at Yale is called the ERACE framework, which was created by the psychiatrists, Matthew Goldenberg and Kirsten Wilkins. And to give you a sense, I feel like I have to have an index card in my coat to carry this. One is and this is sort of the sad piece, you kind of have to expect that the events are going to happen. They are. They're not going to go away. Second, recognize when the mistreatment occurs. Third, address the situation in real time. Fourth, support the provider. And that may be, right, some of this requires nuance. This is not a cookie cutter algorithmic. This is just a framework to help you remember it so that people feel a little more comfortable. It's very unsettling to have that first kind of attack because you're going to have it at some point in your career. How do you provide a supportive climate for the providers and the team? And how do you establish a culture where people feel like, not that you walk into work thinking, all right, I'm expecting this, but that this infrastructure exists. And right, mostly successful infrastructures exist because you have layers of support. To give you some examples of mistreatment, some are obvious. I used to say when a patient would walk into a room and they were cussing up a storm, I would say, Mr. Jones, hospitals are kind of like airplanes. Like when you say bomb on an airplane, you can't kind of do that. You can say it bomb on the New Haven Green in your own car on your bus, but you really can't sort of say F you in the hospital. We have a lot of derogatory language. Some are harder, right? Navigating the microaggressions at the bedside. You have a team of 4 and I'm the woman attending, the senior resident's a woman, the intern is a woman, the student's a male, and the patient comments, calls my resident, Susan, I really love your dress today. Kimberly, I really love your haircut today. And oh, Dr. Jones, that's a great tie. Right. So that's a complimentary comment. So, at that moment, you need to address that situation in real time. You need to potentially kind of create a moment for education and reflection. And that's not meant to be punitive. It's around you can be corrective in a kind of a polite, supportive way. But we this is part of our world. So I'll say there is no one right way to respond. There is one wrong way, and that's not to respond. And I think that's a real cultural shift that we're seeing at our hospital and our medical school, that we are very much, this is not about you having to be alone, because oftentimes I can't do anything. The behavior has happened. I'll get phone calls, at 6 o'clock in the morning from an event that happened the night before, and physicians are rattled by this. So the most important thing I can do is really be there for them and respond and acknowledge that this happened and see what I can try to do to make it better. There are some ways to respond. We've had training workshops for our residents. This paper goes out on every rotation, just an example of setting limits around derogatory language. This sounds easy, still hard to do, Mrs. Z, we don't use that kind of language here. We're trying to help you, which is harder to do when you talk like that. There are times when you've got to step out of the room and bring someone back. So amidst all that, how do you create a supportive culture and support providers and create a positive kind of work environment? This is my kind of favorite part of the talk. One is the partnerships. I can't emphasize so much how over time I've learned the gift and value of partnerships. These are the people, I'm a guest on the floor. I'm there half the time, but these are our individuals. I'll start up here, we'll go clockwise. Roxana, for those of you who know, if you want, you can make and break a hospital unit with the unit secretary. Oh my gosh, that is like command central. Unit secretaries make a floor. This is Roxana, who is the most amazing person in the world. You need to get to know about her son and her family. She is great. Our pharmacy team, Mohammed, they keep us safe. They keep us smart. They're in the workroom working with us. Ellen is, as you can see at Yale New Haven, we have small spaces, cozy spaces. Ellen works with the HIV ID team. And then below, right, it's a partnership. Everyone brings a skill to the institution. This is Eveline, our environmental service person, who keeps our floors spit shining. It's really hard work to do. We have our nurses, right, they're in the trenches every day. You cannot have my care coordination team. I'm sorry. I'm going to give you the first names only. Troy, Jones, and Amanda right up here. It's the hardest job in the hospital system. They have to create infrastructures. They have to basically be part of the team that shares what is possible and what is not possible with patients. Our nurse managers, Kim and Will, and our providers, other partners, Chris Sankey and Nisha Dvani. This is the best part of the job, really trying to solve problems together. And I think that's another lesson for me, is that even though you can't necessarily, a lot of things we can't fix, but it's a whole lot easier if you don't do it alone. And moving to the microclimate for our patient care and teams. Again, I can't control a lot of the big things, but I can control some of the small things. So I take no credit for this, but I'll take tiny credit for it. When I worked at another clinic and moved from there, we had a clinic nurse who had a big filing cabinet that was full of snacks. And the clinic staff loved it because it was, you're kind of working, it's really stressful. You just go open that drawer and like you have a moment of choice. It's like just a brief moment of respite from often a very stressful day. So in our workroom, we have a full candy jar. It is, anyone can come and have it. It's meant, I always just tell them, eat your kale at another time in your life. Do not check your A1C on this rotation. But it's meant to be there as a thank you. It's also some other kind of funny things happen along the way. It's open for anyone. Anybody from the hospital wants to come and have a piece of candy, which is actually what I hear happens, which is fine. That's great. And then something tiny happens every now and then, is that the consulting team, who's very busy, often will, instead of just dropping a note that you read the written recs, will come into the workroom and pick up a piece of candy. And then the team is in the workroom and they stop. And maybe they talk for 30 seconds, and maybe they actually sit down for 30 seconds. And then you have what was once transactional becomes an interaction. And that's kind of the best part of the job. We have medical staff now have their own therapy dogs. We noticed that whenever, this is Lou Siegel here in the wonderful red uniform that I met, and that's Gracie. Who actually is now on many Yale New Haven buses. She's quite famous. But what I noticed when the volunteer therapy dogs were going around the hospital to visit patients, the people who gravitated to those dogs were the staff. And so it took a bit of asking, but we now have Gracie and Gabby and Ace who come and spend time with us on the floors. Just a little bit of time once a week. There's another floor 2 floors down that is like competing and buying specific toys. So we're trying not to compete, but this is just about a microclimate of saying, I'm grateful that you're here. I understand it's stressful. Here, you don't have to go have a piece of candy. You don't have to go pet the dog, but it's just moments of time where you can just for a second relax. And then up here, which I take no credit for, but I like a lot, is a 24-hour live feed of a cat rescue in Defiance, Ohio, which I have to say, I never thought that a cat rescue would be so mesmerizing. And it's just like a moment of, I'm not a smoker, but I think it could be the equivalent of that. Before I have to do a peer-to-peer, just go watch that case. And it's just people like just watching that for a second. So it's just little quirky stuff that we have. For patients, we have patients who are sick for long periods of time, who are here on their birthdays, who are here over the holidays. We buy a lot of birthday balloons at our local grocery store. The nurses, for holidays, we try to, there's a fund that we create to try to make that experience less depersonalizing. I heard about today from Kayla. that may be a bathrobe. We had one patient here who was a long time, and he kept wanting like skiing magazines, and there aren't that many skiing magazines anymore, I have to tell you. So he wanted skiing magazines. He wanted outdoor magazines, right? That's the outdoor piece. I mean, hospital stays for him became almost like a version of a prison. We had a parent gentleman who had paranoid schizophrenia who was hospitalized with a new advanced lung malignancy who had no one and really loved mystery books. So we found him every John Grisham novel that we could. It was just all there by his bedside. And I saw here walking over today, many hospitals have healing gardens, places where the nurses really, I give them a tremendous credit, particularly on the weekends, really try to, when the weather permitting, bring patients outside so they can feel just a little bit, whole. So does all of this matter? Some feedback from the teams, that's our workroom. I get, feedback is a little bit like peeling off the Band-Aid. You're like, ugh. But some of the most surprising feedback I got over time was really from an intern, because I always think, am I teaching enough? Is that chalk talk been good enough? But what's been surprising is often students and physicians have said, I felt safe here. I felt supported here. I felt like I learned so much here because I didn't feel like a failure if I didn't answer the question in a way that I thought I should. And then kind of one of the best ones recently was a student who was just starting their clerkship who said, can I come back for a sub-internship? So we can always get better, but whatever we're doing, people come back. I like that. For patients, we have patient recognition. There's a lot of times when we don't do our job right, but this was a letter that we really celebrated. After what was a harrowing experience with my mom, you all have not been only clinically amazing, you have also been so kind, patient, and reassuring. I hope we will not ever be back, but if we need to, I hope it is this team on 9/7. We did our job. That worked for that one time. We feel proud of that. So just to close, partnerships are really key. I can't emphasize enough how much meaning making that can be, particularly when you feel like you're really stuck, when you're swimming in concrete, when that day is not moving. I think promoting horizontal learning in the workplace is not something that was initially as a PGY 30 was part of my early career, but is very much, I think, makes the learning environment much more welcome, much more interesting. You can do that in a tertiary care center, and the little things matter a lot. So my favorite slide and last slide is my gratitude slide, but I need a picture here of my family today to put that in the center. And that's first a thank you to my parents who, I had a relatively nonlinear journey getting here. And though the CV always shows the best of what you did, there are times when it was not that easy. So I'm really grateful, incredibly grateful for all the support over the decades. Patients, they keep you humble. And then just to give a sense here of my work community, I don't have a lab at Yale, but I work in primary care, I work at a hospital. I got a big Rolodex because I've been doing it for a while. And these are all my colleagues and residents and students, some of the residents who are now attending, which is great because I can call them immediately if I have a question. And then I didn't realize subconsciously that in the right lower quadrant are all the surgeons that I work with. And then I'll close with selected references and take questions. And thank you very much.
Well, thank you very much, Dr. Berlin. We've got about 7 minutes here for questions. We've got one that's come in online, but maybe let's first start here in the room. Do we have a question?
Well, thank you very much for that talk about primary care. And as a internist, general internist who finished my residency 41 years ago, I had 20 years of inpatient and outpatient experience and 20 years of just being an outpatient internist. I fully appreciate the jar of candy because when I was doing inpatient, outpatient, the interaction with specialists in the hallway was invaluable. And when I moved to the West Side and I didn't, I mean, it became totally transactional and worse with COVID. I mean,
Yeah.
I didn't know any of the consultants. I never went to the hospital. There was, well, except to go to grand rounds. But I just want a little more in feedback on the transactional versus the interactional, because I think interaction is critical for providing quality care.
Yeah, thank you for that question. I mean, right, so I mean, the hard part of the balance is, whether there's the files, paintings of the doctor that we sort of all nostalgically look at, which, some part of your job has to be transactional. You're never going to get through the day. And so then there's that balance of when do I create that time so something's not transactional. And right, transactional is a subjective, right? It's in the eye of the beholder. So if you're a cardiology consultant, you have 40 consults you've got to get through the day, they're going to be transactional. But I think if you can create moments where you have interactions, where you're humans, where you're colleagues, you can't do it all the time. You can do it some of the time. You can build into that, just makes the experience much more enriching. I think that's kind of the fun of the inpatient workplace, right? You can do radiology rounds, you can do a field trip together. So, we do a lot of that as part of the teaching experience, where bonding is one term for it, but there's a lot, right? We have technology has made us very transactional now. So that's part of the priority of communication. Really, when we even talk about plans for the day for a patient, our goal is like, find the nurse, bring the nurse in, have a conversation, identify what are their priorities for the day, what concerns do they have for the day, and then what are yours? That doesn't take that long, but it doesn't, but there are going to be other parts of your job where it's going to be transactional. So I think even awareness of it is a start. But it's not perfect. I mean, there are times when, right, provider fatigue, there are times when you're tired, and that if you can just get through the day safely. But candy is a piece of it. It's not just the only thing, but it's pieces of where you encourage places for interactions. And then it's much more fun. It contributes, it's hard to measure, less burnout. So yeah, thank you for that question. You're right.
Thank you so much. As a recovering program director, I'm interested in this sort of horizontal learning and how I know your father, high standards. So how do you find that balance between support, but still having high expectations of your learners?
Yeah, that's a great question, right? So say you have a learner, we have preliminary interns who come with us, and let's say someone is going into, I'm just going to say we have a preliminary intern and they never had a sub-internship. So they're, it's not fair to expect them to kind of start at that place. And if you set that expectation, then you're already creating a place for them to fail. So some of it is right. Some of it's the balance of time. If you have an unstable patient or a highly complex patient, you can't spend X amount of time working through a patient. And right, and also this isn't July of 2026 is going to be different than January of 2027. But I think the notion that, let's say someone presented the overnight admission and it was a little rusty, you could do one or two things. You could criticize that, or you could say, you did it. You presented your first overnight admission. You did it, right? Way to go. And then you can make that better. Or say maybe like a, communication at the bedside was like, you're like, ooh. But you can make that better. In a way, as opposed to identifying a deficiency. How'd that go? I'm like, and I think that's right. Communication is a process, not a one-time experience. So, but it's hard. It's hard. Or if you have a learner that's struggling, I often, where I've learned over time, is that if a learner is struggling, it's not because there's usually something else going on. It's not about poor work ethic. It's about something else that's going on. And so how do you create those unique supportive environments for them? And so for the most part, we're really lucky at Yale. We get nice people. And so I think the thing is how to kind of preserve who they came in as and kind of still keep that mission. Because, you know, a lot of our residents will go into a different specialty, but that doesn't mean you can't learn something in that moment. And that's why, so the horizontal workspace is around, we are all learners, we all make mistakes. So it's not, the burden is not on one person to do all things, which ties into, I'm going to talk a little bit tomorrow around vulnerability. And it just makes the learning environment just much more interesting. So.
What I love about this talk is the conversation on communication and the microcultures. It sort of makes me think, while we hear a lot about how broken our systems are at a national level, within some of our big health systems, we are the ones that we've been waiting for. And there are maybe some strategies we have to engage. And I love this conversation. I'll end with a comment that we have from the chat. This is connected to when you were reflecting on the themes or the priorities that the Whitman team has on your unit in talking to patients about maybe struggling with substance use disorders, and it's not your fault. What are some concrete strategies used by the firm to minimize depersonalization and stigma bias? What other sorts of strategies, communication styles?
Well, I mean, there's the commit to sit, right? So, you know, part of that is just actually what your body language is at the bedside. Sitting, not crossing your arms. Potentially, if you're going to have a conversation about at-risk alcohol use, which may not be the reason that they're here, but that became part of that. That may not necessarily mean a whole team of people coming into the bedside and standing and having that conversation. So some of it is about personalizing that, making sure that they give you permission, to talk about it, permission to disclose. I really have been astonished at how, a med student will kneel down at the bedside and just say, thank you so much for talking about this. It's really okay. Is it okay if we can connect you to some resources here? And maybe that's something you want to do today or just something that you want to think about. It's really not through the lens of a punitive approach. I said we are really lucky. We have a phenomenal addiction medicine team at Yale. And we also have medications that can help people too. It's not just about willpower, right? I mean, naltrexone, the number of needed to treat is like better than a statin. So it's not only, so I think the notion is that doesn't happen right now. It just says that we're here potentially something, resources for you later going forward. And often, they'll come and they'll say, well, my ex, right, there's all tied to punitive stuff. So much punitive. It's your fault, right? It makes it easier from a societal standpoint to make it your problem because then we don't have to create infrastructure to help them. So, we have patients who have diagnoses that years ago were incredibly stigmatized. So some of it's around the birthdays, right? Some of it's around the holidays. Some of it's around things that make them human again. So I think stigma reduction happens when that is a person first, as opposed to a diagnosis, and trying to recognize that this isn't. It's not about me. Even if the behavior doesn't change, because often it will not. At least you have that awareness, and at that moment in time, they felt okay disclosing, and maybe that's just enough.
Well, I can't think of a better way to start our two-day Goldman Berlin Lectureship in Palliative Medicine. Thank you very much. Won't you help me thank Dr. Gretchen Berlin?